Hey guys, it's Matt with AEC, and I wanted to spend just a couple minutes going over Verapamil. So Verapamil is another one of our calcium channel blockers. We also have cardizem that we review in our program, and it's pretty commonly used. I would say cardizem or diltiazem is one that's used a little bit more than Verapamil, and we're going to talk about why in just a moment. Like I said, it's another one of our calcium channel blockers. It kind of works from slowing down calcium entering the cell during that action potential, during repolarization. So we can see because of that, we're going to have what they call negative inotropic and chronotropic effects, meaning that this is one of our true rate control meds. So that chronotropy, that is the overall rate. So we're going to see the heart rate slow down from this, but also we're not going to get as hard of a squeeze or contraction from the heart as well. As another effect too, it also works on the blood vessels as well. It causes smooth muscle relaxation, so we're going to see a little bit of vasodilation because of that, and a drop in blood pressure. It is kind of like the intended effect from this medication sometimes. However, compared to other calcium channel blockers, and especially cardizem or diltiazem that we definitely have in our pharmacology manual, this is one that has more of those vasodilatory effects. So one of the sometimes unaffected side effect of this is we're using it to treat the dysrhythmia. The heart rate's really high. We just want to get this back down. Well, if we're not paying attention and the blood pressure is already on the lower side, we can definitely bottom them out. So it's definitely something to look out for. So when do we use this? Well, we use this, it's our frontline choice for AFib and A-flutter, especially when they get over 120 beats per minute per our pharmacology manual. And then we also can use this for refractory SVT when vagals and adenosine hasn't worked. We kind of have a choice of beta blockers or calcium channel blockers that we can use, and this is one of those. It's contraindicated just like that other list on cardizem and diltiazem. We're not going to use this in our higher degree AD blocks, so our second degree and third degree heart blocks. We're not going to use it for sick sinus syndrome and also acute MIs. And also, finally, we can see that just like a lot of other meds in our cardiology section, it's one of those ones that we have to watch out for with Wolff-Parkinson-White. It's not an absolute contraindication, but certainly something we typically have to call med control before we get permission to use it. The dose for this is pretty straightforward, especially compared to our diltiazem or cardizem. So this is just a straight dose. It's not a weight-based dose. So for adults, it's going to be 2.5 milligrams to 5 milligrams IVIO, and we're going to give that over 2 minutes. Like a lot of our other rate control meds, if we just slam it home and give that rapid IV push, we can actually bottom them out completely. So we need to give that a little bit over time. So for this one, over 2 minutes. And then we can repeat that after 15 to 30 minutes. So one of the longer wait times we have in between some of these doses that we have. And then we can give at that point 5 to 10 milligrams.